along with Vinay Mayo, who is our CME coordinator, and Jennifer Goodman, who manages nursing CE credits. The program this evening provides 1 hour Category 1 physician AMA CME and 1 hour of Virginia Nursing Association CE credit. Sova Health is accredited by the Southern State CME Collaborative for providing physician CME. It is also accredited by the American Nurses Association Center Commission on Accreditation to provide nursing CE credit. The program was developed this evening with an effort to promote two desirable physician attributes, that being our providing patient-centered care, utilizing and utilizing or employing evidence-based medicine. The need for this program came from our annual medical staff needs assessment, which was to identify aberrant presentations on EKG of acute STEMI events. Dr. Newby reported several commercial relationships with what are known in the CME world as ineligible entities over the past 2 years. These are listed for you here, which include research grants and serving as a consultant. Dr. Newby's agreed to mitigate these by providing her slides for CME review before the program, which I have done, and there's no evidence of commercial bias, and that she will be in situations in which there are any clinical recommendations. These will all be evidence-based medicine, free of any commercial bias and or from consensus guidelines. In addition, the material she's presenting tonight really does not relate to any of the relationships she has as far as these commercial entities. Otherwise, Dr. Mitchell, our moderator, others that help plan this program, as well as myself and the Sova Health CME committee, have no commercial relationships to disclose to you. There is no commercial support of the program this evening. It is supported by the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the local urology and nephrology practice, upon his retirement, gave a generous amount of money to establish a continuing fund to support medical education for all types of healthcare providers in our community. This fund allows us to have excellent speakers such as Dr. Newby participate in our teaching programs. At the end of the program or through a QR code link, your choice, we will be sending you, or you may log on to an evaluation form, which we ask you to take a few minutes to fill out. On that form, among the 7 questions, number 4, ask, are you planning to make any changes based on what you learned in your daily practice? This is meant for everyone, not just the physicians. All of us, no matter what type of healthcare professional we are, practice our skill sets within our level of skills for caring for patients. So take a few minutes to complete that. For the nurses and nurse practitioners on the call, you must complete an evaluation in order that you are able to receive CE credit. Besides us emailing out to you a registration or an evaluation form, you will see a QR code appear in the chat during the final few minutes of the program, and you can log on through that to get your evaluation form if you prefer to do that. For the residents on our call this evening, the Sova residents, you do not have to keep up with your CME certificates, so we provide the list of who was here this evening to your CME coordinators, and they look after that for you. When you complete that evaluation form, it asks you to re-enter your email and your full name. Please give us your full name, because that's what will appear on the CME certificate that we will subsequently email to you. So please don't use any short names, nicknames, or things of that nature. This evening, if someone is logged on with you, watching the program, listening to the program, please let us know about that so that we can be sure they receive credit for the program. This past few days, we have had problems with our registration software. And so many of you this evening, including myself, logged on through a link that we basically said, if you want to come on down, and you don't have to pre-register. It's important that if you logged on in that manner, that you enter your name and your email address in the chat right now. As soon as you've logged on, please put it in so we know absolutely that we have everybody on our list and we can be sure you not only get the eval form, but more importantly, you get your CME certificate. And that being said, since you're not logged on through the system formally, please make sure your microphone is muted during the program. If anyone has any questions about this process for this particular program, please reach out to myself or Vinay Mayo or Jennifer Goodman, and our emails are here. And as I do every time we do a program, I just want to particularly thank Vinay and Jennifer for their unbelievable help, particularly in us overcoming with a workaround the issues about logging on this evening. Please be aware of this. Dr. Newby very much wants us to be a conversational evening session. She wants questions and interactions with it. Normally, if we were in a room together in a teaching conference room, she, like myself, and I know Dr. Mitchell does the same thing, we would be engaging you verbally. So there are no dumb questions. You're among friends tonight. And so either please speak up or put it in the chat when she asks a question. And then we want to hear from you. Once you have responded, when you listen to her response, please mute your phone so we don't have feedback. Very briefly, I want to highlight the next upcoming programs. In 2 weeks, on Thursday night, March 26th, we will have, if you will, a double header on antimicrobial and infectious disease stewardship. We'll have an update by Dr. Ariel Cohen first, one of the Duke DASON members. That's the Duke Center for Antimicrobial Stewardship, in which we participate. And she'll talk about the changes and the different antibiotic resistances and so forth that have been occurring at Sova Health on both campuses as we do this each year. And then new this year is we're having a second talk on diagnostic stewardship and working up infectious disease. How many blood cultures do you really need? When do you need to do a throat culture? Is a urine reflex urine culture better than going and getting a separate culture? These type of best ways to do a diagnosis of infections is something that Dr. Mooring will be covering for us that evening. And then 2 weeks after that, on Thursday, April 9th, we'll have a review of the current rising prevalence of tuberculosis in communities across this country. And Dr. Nick Turner from Duke Infectious Disease will be doing that. That being said, I'm delighted tonight to announce that this is the first in our series of emergency medicine CME programs. Dr. Michelle Mitchell, who is team leader for Team Health in our Danville ER, along with Bruce Mazak, who is the team leader for the Martinsville Team Health Group. They have come up with an idea that we would once a quarter have an emergency medicine or acute trauma program, and we will be doing this the first Thursday night in the first week or month of each quarter. So we're doing this one in March. There'll be one in June, September, and December. And we are just delighted to have this happen. So Dr. Mitchell, who helped us create this program this evening, she's going to come on, moderate the program, and introduce Dr. Newby. Dr. Newby, you can bring your slides up. And as Dr. Mitchell starts to introduce you, and then we'll get underway. Thanks so much to everybody.
Thank you, Dr. Moore. I'm very excited about this upcoming CME series geared towards emergency medicine. And with that being said, I'm going to introduce Dr. Kristen Newby. She completed her medical degree from Indiana University and then a residency in internal medicine and a cardiology fellowship at Duke University. During her education and training, she was inducted into Phi Beta Kappa and Alpha Omega Alpha. Currently, she is a professor in medicine with tenure in the Division of Cardiology, and she's also the director of the Cardiac Intensive Care Unit at Duke University Hospital. In addition to her clinical role, she is a distinguished researcher. She has authored more than 530 peer-reviewed publications and has almost 81,000 citations. Most recently, she's been named in the top 1,000 female researchers in the world for multiple years in a row. And we are honored to have Dr. Newby presenting about STEMIs. Thank you.
So thank you for that kind introduction, and to both you and Dr. Moore for inviting me to participate in your inaugural session. As you can see on the screen, we're going to be talking about electrocardiograms tonight, and that'll be pretty much the focus for the entire evening. I'll try to get everybody on the same page. I recognize that there is a spectrum of learners to advanced clinicians on the program. So some of this may be simple for the advanced practitioners, but I think it'll be good just to have the background so we're all on the same page. And then we'll just dive in and start looking at electrocardiograms and particularly variants of electrocardiograms in STEMI. Let me see if I can get, I'm having a moment here, trying to get there we go. Get my slides to advance. These, again, are my disclosures. None of these relationships are really relevant to electrocardiography or the content that we're going to talk about tonight, and I won't be discussing any off-label uses of drugs or devices. So as I think about the electrocardiogram, and again, just to get us on the same page, I always encourage taking a systematic approach to reading the 12-lead electrocardiogram. And I think some of the electrocardiograms I show you will help reinforce why we do this. So systematically, we need to look at the rate. And, I think for most purposes that we get it exactly at 63 beats per minute or 77 or 42 is probably not important. The thing is to recognize, are we going fast or are we going slow? Fast being greater than 100 beats per minute, slow being less than 50 beats per minute. And that helps you start thinking about what the rhythm is, which is the next thing that we look at. And the really simplistic way of thinking about this is there a P for every QRS? And is there a QRS for every P wave? And answering those questions will pretty much take us to what rhythm category we're in. Then we look at the axis. I'm going to talk a little bit about Einthoven's triangle because I think it's an undertaught tool for determining the axis. Normal axis is minus 30 to plus 90 degrees, and you'll see what I mean by that as we talk a little bit more about Einthoven's triangle and the axis. Then we'll talk about the next thing being looking at the intervals. Is the PR long, or is it normal, or is it short? What's the QRS look like? And what is, importantly, when we're talking about ischemia, what is the QT or corrected QT interval look like? And I put in some normals here. It's easy to put in normals for the PR and QRS intervals and what the abnormal ranges are. And I won't go through each one of these in detail, but pause here for a minute for you to look at those. And they will come in as we move through the electrocardiograms. I didn't put normals here for the QT interval, and the reason for that, and the reason we have a corrected QT interval, is the QT interval changes with heart rate. So normally the QT interval will shorten as the heart rate increases, and it will lengthen as the heart rate slows. A general rule for thinking about the QT interval is if it's less than half the R to R interval, it's probably okay. So these are just some high level things to get us all on the same page so that we're thinking about the electrocardiograms and looking for signals on them in the same way. The last thing we start looking for is the ST and T wave changes, which is, for the purposes of this talk, our ischemia assessment. And again, those are the things that often jump out at us, but we don't want to miss any of these other things. So always a systematic approach. The more experienced you get, the faster you will go through this systematic approach. It will just become second nature. So let's take a minute to talk about axis. And Einthoven's triangle really is an imaginary triangle that's formed around the heart by the 3 limb electrodes. And the limb electrodes are the right arm, the left arm, and the left leg. The ground electrode is the right leg. We need to remember that current flows from the cathode to the anode. So if you see the human here on the left side, you can kind of see how the triangle forms between the right arm, left arm, and left leg, and the heart clearly is right in the center of that triangle. And then if you look to the right side, you see that current flows from the right arm to the left arm, the right arm to the left leg, and the left arm to the left leg. And that defines leads 1, 2, and 3 in the kind of, if you will, frontal plane. And if you think about the way electricity flows through the heart, it flows from the right atrium or upper right through the heart, the AV node, down to the ventricles. So in a general direction from the upper right to the lower left. And if the electricity in the heart is flowing in the same direction as the polarity of these leads, you'll write an upright QRS. If it's flowing in the opposite direction, you'll write an inverted or a big S wave. So most of the QRS complex will be downward pointing. Then from this frontal plane, we can derive the other leads, the other surface leads, and those are AVR, AVL, and AVF. AVR is directed upward from the center, from the heart, up towards the right arm. AVL is directed up towards the left arm, and AVF points down towards the feet, if we're thinking about the body on the left and the triangle on the right. And then you can see the axis. 90 degrees is pointing straight down, 0 degrees is pointing directly to the left, minus 90 is towards the head, and minus 80 is towards the 180, positive 180 is towards the right side of the individual. So just keep that in mind, and we'll take a look at an EKG here, and we'll put all that together. So here's a normal electrocardiogram. Now this, what you'll notice as we go through these electrocardiograms, only on the ones that I'm not going to make you pause to think about them, will I put a header on these, so that you can look at these slides later. The header will it will appear after we talk about the EKG. So if we look at this electrocardiogram, normal electrocardiogram, and we think about that Einthoven's triangle, we see that we're writing an upright QRS in 1, which is pointed towards the left shoulder. We're writing an upright QRS in AVL, again, up here towards the left shoulder. And our QRSs are upright in leads 2, 3, and F. And if you will just take a peek back, all of those leads are kind of following the direction of electricity through the heart from the upper right to the lower left. So we would expect to see these upright QRSs in the inferior leads, and they're upright in 1 and L because the general direction is from right to left. AVR should always be an inverted lead, and that's because it's directly opposite to the polarity of that lead current. The current flow is towards the feet, not towards the head. So AVR, which is looking up here at the right shoulder, should always be an inverted lead. And then if you look at this, all the other things hold. The PR interval is less than 1 large box, which is 20 milliseconds. The QRS duration is less, it's about probably 0.06 here, 0.08. And the QT interval is well less than half the R to R. And if we look at our STs, we don't see anything that looks abnormal. There's no T-wave inversions. There is no ST segment elevation or depression. So this is a normal electrocardiogram with a normal axis and normal sinus rhythm. So now let's look at this EKG in contrast, and I'll just give a moment for folks to look at it and think about what strikes you as different about this electrocardiogram than the one I just showed you. So just take a moment, look at that. If anybody wants to come off mute and say what they see, that's fine as well. I know it's a little difficult when we're in the Zoom medium to do that. Okay, so everybody's had a chance.
One and AVR are not the right axis, and the limb leads don't line up with the axis you see in the precordial leads, so it's likely lead reversal.
Excellent, excellent. That sounded like an experienced clinician to me. So yes, the first thing you notice is that leads 1 and L are inverted leads now. And AVR is upright. And just remember what I told you, AVR should never be upright. Current does not flow up towards the right shoulder in the heart. It flows down towards the feet. So this is the most common limb lead reversal, which is simply flipping the right arm and the left arm. Fortunately, we don't see it every day. But this is an easy one to pick up, and it makes up the majority of the limb lead reversals. And all you need to do there is just ask to have the ECG repeated. Okay, so with that kind of as our kind of level setting and background, let's go to looking at some electrocardiograms. So I'm just going to frame a case here, and I may vary the background a little bit as we move through these, as we get to different electrocardiograms. But in general, this is a pretty generic case. We've got a man who comes to the emergency department, 55 years old. He's complaining of chest pressure. It's been going on for a couple hours, waxing and waning. But it became constant about an hour before he came to the emergency department. He is a cigarette smoker. He has hypertension. He's never had his lipids or his hemoglobin A1C checked, or at least he doesn't remember having them checked. And his only medication is amlodipine 5 milligrams daily.
It's still wet.
I'm sorry. Okay. We'll keep going. So my question for the group, and again, what is the first test now that we should do to evaluate this man? So this is pretty straightforward. It's the 12-lead electrocardiogram. And for all patients who come in with chest pain to the emergency room, we want to try to get this 12-lead electrocardiogram within 10 minutes of patient arrival. And the goal here is to minimize the time to getting an artery open in patients who are having a STEMI. And the diagnosis of STEMI is purely by the 12-lead electrocardiogram. So 12-lead ECG within 10 minutes of arrival. So this is the electrocardiogram that we have in this man. So take a minute to look at it, and then we'll kind of go through it systematically. I put it in here just to emphasize that we need to look at everything on the electrocardiogram, not just the obvious. So if we look at the heart rate, it's right about 100. It looks like there is a P for every QRS and a QRS for every P, so it's sinus tachycardia. The axis, he's up in 1 and L, so we're towards the left. AVR is an inverted lead. You can see the P waves and the QRS and the T waves are all relatively upside down, if you will. So it's an inverted lead. So we don't think there's a limb lead reversal or anything else going on. But we do notice that the electrical direction is down in 2, 3, and F. And remember, if the current is flowing in the heart from the upper right to the lower left, we should write a more positive than negative QRS complex in leads 2, 3, and F. So when we see this, we can call this immediately an extreme left axis. That means it's pointing up here towards the left shoulder, so away from the feet, but still towards the left. And that is referred to as a left anterior fascicular block. So that's a little more advanced EKG for the more experienced providers, but also a good thing to know for folks who are learning electrocardiograms. The QT interval looks okay. It's about half the R to R. But the most striking thing here is what everybody's eye went to immediately, right? We see ST segment elevation in leads 1 and L, so the high lateral leads. We see ST segment elevation in V1 through V5, so the anterior lateral leads. So this would be an acute anterior lateral STEMI. So that was a pretty straightforward EKG. I didn't point out, and I should have, that there's some ST segment depression that you see in leads 2, 3, and F, or the inferior leads. So that would be reciprocal depression. So obviously we see this one, and we call in our cath lab colleagues. So let's take a moment. We'll have the same 55-year-old man in front of us, and just take a pause to look at this electrocardiogram. So much less dramatic than the one I showed you before, but with our systematic approach, it looks like it's sinus rhythm. The axis in this case looks normal. There's upright QRSs in the inferior leads and also upright in 1 and L. So the axis is normal. And the QT interval looks okay. The QRS is narrow. The PR interval looks normal. And again, we see more subtle, but I think still clear ST segment elevation. And we look at this at 60 milliseconds after the J point. So we're looking, so the J point is right in here. So we're looking right out in here, and we're looking for ST segment elevation of at least 1 millimeter in the limb leads. And I won't get into sex differences, but let's just say 2 millimeters in the precordial lead, so V1 through V6. And I think, again, we see ST segment elevation in 1 and L, which are the high lateral looking leads. We see ST segment elevation in V2 through V4. I might argue even out into V5, although it's much more subtle. And then we see the same reciprocal ST segment depressions in leads 2, 3, and F. So this is just a less dramatic presentation of an anterolateral STEMI with reciprocal inferior ST segment depression. So nothing terribly variant here, but just every STEMI looks different. All right, so let's look at this EKG. This is kind of an interesting one. Again, let's take our systematic approach. The only thing I would say here is that in some leads, the the PR interval looks a little bit short. Although I think overall, when we get out a little bit, the PR interval looks okay. the interesting thing here is the P waves are inverted. So we're looking at a lower atrial focus for this rhythm. So we wouldn't call this sinus rhythm, but it is an atrial initiated rhythm. The QRS is narrow. The QT interval looks less than half the R to R, pretty short. Nothing particularly surprising there. And then the obvious thing we see is a little bit of ST segment depression and T wave inversion in leads 3 and F. But look at those T waves and kind of the ST segment that's a little bit sloping up into these really peaked, pointed T waves. And this is a specific electrocardiographic pattern that's called De Winter sign. And I've shown you one pattern here, but there are actually 3 patterns of these kind of hyperacute or very pointed T waves with variations in what the ST segments look like. You can see there's one that's kind of sloping right up into the T wave, one that's a little bit more flat, like we would normally think of ST segment depression. And then there's just these big hyperacute T waves. And these are kind of, I would call them not STEMI, but maybe pre-STEMI may evolve ultimately into STEMI if you do serial electrocardiograms. But it's certainly a high-risk electrocardiogram in a patient who's presenting with chest discomfort, whether that's very typical or even variants of atypical. You should be worried when you see this as an ischemic ECG finding. May not be an occluded artery. If the patient's pain-free, you might not even rush them immediately to the cath lab, but you would certainly want them to be, if possible, to get them to the cath lab as soon as possible. You wouldn't sit on this patient. But this is what we mean by De Winter sign. Here's another.
A question for the last one. So are the peak T waves just not diffuse enough to consider hyperkalemia?
That's a great question. Yeah, that's a great question. You would see T waves that look very much like particularly this middle box in hyperkalemia. Right. What you wouldn't see is these unusual J-point depression, ST segment flattening and depression, or even here a little hint of elevation. So you would see mostly a baseline level ST, but these very high peaked T waves. So they could look like this. You just wouldn't see these other kind of more characteristic features of ischemia.
Yeah, before you put the overlay of the De Winter sign, the original EKG, I kind of focused in on the peak T's.
I went the wrong way.
Maybe it would be
Yeah. So exactly, this is what hyperkalemic T waves look like. But then you look down here and you see this kind of depression of the J point and this upsloping, and that's what defines it as De Winter. And if you look out here, it's depressed and then goes into these upsloping T waves. And you don't really see that in hyperkalemia.
All right, thanks.
Yeah. And for the learners on the call, the way I was taught, if it looks like it would hurt to sit on it, it's not good, but you may not know why it's not good. So just remember, these should prompt you to think what else is going on, and then you have to start looking at the complex a little bit more carefully. You'll obviously be getting your labs back. You'll know what the potassium is, but this is pretty classic De Winters here with these ST depressions that you shouldn't really see in hyperkalemia. Great question.
Hey, Dr. Newby, I had a
Uh-huh.
question too. In terms of like sinus rhythm for this one,
Yeah.
the P waves are kind of inverted in 2, 3
I'm going the wrong way. Sorry.
AVF. So wouldn't that kind of indicate like ectopic atrial activation?
Yeah, that's what I'm saying. This rhythm is coming from lower in the atrium. It's not at the sinus node, but exactly. This is an ectopic atrial rhythm. You know,
Awesome.
it's you know, the P waves are upright in 1 and L, which they should be. It's just these down here in the inferior leads are a little bit off in some of the anterior leads. But yes, good point. Okay, let's go to this one. This is another another kind of I'll just say it should get your attention, but let's go through it systematically. It looks like we have sinus rhythm, not particularly fast or slow. The inferior leads are all upright QRS complexes, AVRs inverted as it should be. We're over towards the left with an upright QRS in 1. A little bit, I would call it more isoelectric. There's a little bit of movement here in AVL, but we're left and we're down. So the axis is normal, but you know, maybe not quite as leftward as in the previous EKGs I've shown you. The QT interval looks okay, and so now we're going to look at, you know, what else is going on. And I think everybody's eye probably went immediately to these precordial leads, and you don't see ST segment elevation here that meets criteria for STEMI, but you notice these kind of deep symmetrical T wave inversions. And you know, there's a few situations that you see deep symmetrical T wave inversions like this. You can see it in kind of catastrophic intracranial processes. They tend to not have this little bit of coving of the ST in that situation. They go more straight down and straight back up. But this is another classic variant of an ischemic EKG. Doesn't meet criteria for STEMI, but it should get your attention. We sometimes even see these in patients who walk into our clinics for evaluation, maybe even of just exertional chest discomfort. But this is either pre-STEMI, pre-MI, or chronic ischemia that usually reflects disease in the proximal left anterior descending artery. And this is what we call Wellens syndrome. So these are Wellens T waves. And again, proximal LAD or potentially distal left main proximal LAD lesions. So this should get your attention. If they come to you in your outpatient clinic, they should get referred for further evaluation with coronary angiography. You wouldn't want to do a stress test here because this pattern does suggest you've got a tight lesion, and you put those folks on a treadmill, and you could you know, certainly precipitate an MI or fibrillate them or other things that you don't want to do. So these folks should get evaluated. If they're in the emergency department, again, this is kind of like the winter sign. We should be thinking this is a high risk ECG, high risk patient. Maybe not activate the cath lab immediately, but if they're having ongoing chest pain, you know, cath them sooner as opposed to later, even if you're not seeing the ST segment elevation. And you definitely want to get serial electrocardiograms to make sure these don't evolve into ST segment elevation. So I'll pause there, make sure there's no questions about Wellens syndrome and what we're looking at with Wellens syndrome. Okay. All right. Here's another good EKG. This was a fairly recent case that we had. So again, let's be systematic. It looks like we've got P waves and we've got QRSs for each P wave and vice versa. So we're sinus rhythm, about 100 beats per minute. So probably sinus tach. The axis looks okay. AVL's a very low voltage lead, but we're up in 1, and our QRSs are upward in 2, 3, and F. So the axis is normal. The QT interval is getting out there. Don't like to see the QT end where the P wave begins. So we're just right at half the R to R. And for the learners on the call, just remember the most common cause of QT prolongation is ischemia. There's a lot of genetic QT prolongation, et cetera. Drugs can do it, but the most common cause, simply because ischemia is the most common presentation, is ischemia. So a little bit long QT. And then we start looking at what else are we seeing. And the most obvious thing is we've got pretty dramatic ST segment elevation in the inferior leads. And then we look at the high lateral leads, and particularly in AVL, we see pretty significant ST segment depression. This is the isoelectric line here, and we're well depressed below that. And we also see ST segment depression in leads V2, 3, and a little bit out into V4. So this is, to use our lead groupings, this is an inferior myocardial infarction with reciprocal ST segment depression. And I should have said anterior and lateral, high lateral ST segment depression. Apologies on that. So this is a pretty, it's kind of like the first anterior STEMI I showed you. It's pretty obvious. We're probably not gonna miss this one when we get this EKG. All right, so let's look at this one. This is kind of an interesting one. And this EKG is the best example of why we always look at the rate and the rhythm first. So is it fast or slow? It's pretty slow, right? Probably in the 40 to upper 30s rate here. So pretty slow. Then we go through and we look at this first beat. It looks like there's a P for that QRS. But then as we start looking, we notice, oh, what's that little bump right there at the end of the T wave? What's that? What's that up there? And there's one there that's probably not conducted. And then we look over here, we see a couple more. And they don't seem to be in any way associated with the QRS complexes. So this, we've got an atrial rhythm that's moving through, and we've got an escape rhythm. So this is complete heart block. And obviously we want to know that, and we don't want to get so focused on the other obvious abnormalities that we miss the complete heart block here. It's hard to say the QT interval, but it's certainly less than half the R to R in this escape rhythm. And the QRS duration, sorry, I should have done that first. It's pretty narrow, complex. So, we've got some kind of a junctional escape rhythm here. It's not a ventricular escape. So we feel a little bit better about that with complete heart block than if we saw a left or right bundle branch pattern, a big wide QRS complex. So then the next thing we start looking for is ischemia, and we see in our inferior leads 2, 3, and F, we've got this pretty dramatic ST segment elevation. And then we notice in 1 and L, we've got pretty dramatic ST segment depression, same out here in V2 and 3, that extends out here further into the anterior lead. So this looks a lot like the EKG I just showed you. So it's an inferior MI with ST segment elevation MI with anterolateral reciprocal ST segment depression. The difference here is now we're dealing with complete heart block, and complete heart block is, it's certainly not, I wouldn't call it common with inferior myocardial infarction, but it probably reflects vagal tone. We worry less about complete heart block in RCA inferior myocardial infarctions than we do anterior myocardial infarctions, where we've more likely made the conduction system directly ischemic in an anterior myocardial infarction. So we wouldn't necessarily put a pacemaker in this patient if they were hemodynamically stable with this rhythm. We would just get them to the cath lab, open the right coronary, and then you might have external pads on, but you would monitor them. Whereas in an anterior MI, you would likely put a temporary pacing wire in. So this is an example of an inferior STEMI with complete heart block. Okay, let's look at this electrocardiogram. And again, sinus rhythm, the axis looks pretty normal. Our QRS duration, PR interval, QT interval, all look pretty good. And, the patient's having a fair bit of chest pain. And we see kind of some subtle inferior changes, maybe a bit more in lead 3, a little bit of an irregular baseline. What are we doing? We see a little bit of elevation maybe here. So we're not sure exactly what we've got. So we do this. So it looks like an inferior MI, more subtle than what I gave you before. We don't see a lot of ST depression, maybe some here in the high lateral leads 1 and L. So we do some additional leads, and these are what are called right-sided leads, and they're probably something we should do more frequently when we have an inferior myocardial infarction. And what we're specifically looking for here is, have we a situation in which the inferior myocardial infarction, or the occlusion of 95% of the time, the right coronary artery, has that affected the right ventricle? And so what we do is we place what are called right-sided precordial leads. And they are simply a mirror image of the normal precordial leads that we put on. And we call them V1R, V2R, V3R, V4R, V5R, and V6R. So they, instead of going around the left side of the chest, they come across and go around the right side of the chest. And remember, the right ventricle is an anterior and right-sided structure. So we want to get a better look at the right ventricle. And if we see at least a millimeter on average, and there are some sex-specific recommendations on this, but in general, look for a millimeter in V4R, and that's diagnostic of a inferior STEMI with right ventricular involvement. And you might say, well, that's great, but it takes me time to put these leads on. Why do I care? The real reason that it's important to know this is these individuals can be very volume sensitive, particularly if they're hypotensive, you want to give them a lot of volume so they have preload, because it means the RV is just sitting there as a passive conduit. It's not contracting, it's not moving blood flow through. So they're preload dependent. So when you see this, definitely don't give them nitroglycerin, which reduces preload, and give them a lot of volume. And sometimes it takes, and I don't mean 250 cc's of normal saline, I mean liters of volume to stabilize somebody with an RV infarction. So just a little pearl, if you got somebody hypotensive, inferior MI, do the right ventricular, right-sided leads to take a look at whether you've got RV involvement. So again, our RV infarction shown by the right-sided chest leads. Okay, here's another one that we don't want to miss. We've got sinus rhythm. We've got a little bit of a wide QRS, but not bundle branch block wide. The QT interval looks pretty good. The axis is a little bit leftward. If you look at 2, 3, and F, most of our forces are pointing away from the feet. So our axis is more up here towards leads 1 and L, the left shoulder. So we've got a left anterior fascicular block. And then we start looking for what else might be going on. And all we really see on this EKG may be a hint of a little bit of just not normal ST segments here, but may not quite meet a millimeter. And we notice this ST segment depression in leads V1 through V3. The other thing that's a little abnormal here is we start writing a pretty upright R wave even in V1 and substantially here in V2. And so everybody's probably trying to think, what am I getting at least the less experienced providers. But this is what a posterior myocardial infarction looks like, isolated posterior myocardial infarction on the 12-lead EKG. And it's really characterized by writing this large QRS R wave here, R greater than S in lead V2, where it's greater than either V1 and almost as big as V3, and these ST segment depressions in the anterior leads. And basically, you can say if I put this upside down in a mirror, it would look like a Q wave with ST segment elevation. And so basically, it's an infarct on the backside of the heart away from our precordial leads. So that's why kind of flipping it upside down in the mirror makes it look like a more typical ST segment elevation myocardial infarction. So this is a posterior, isolated posterior STEMI. Most of the time when we have posterior infarction, we see something in the inferior or the high lateral leads, but this is pretty much isolated posterior MI. So I'll show another similar example, and this one's a little less obvious. Again, we have these kind of suspicious looking ST segments in the inferior leads. We're looking out here on the high lateral leads. Looks like we've, maybe here, particularly in V6, does it quite meet criteria? Probably not. But again, we notice these ST segment depressions in V2 and V3, but unlike the EKG I showed you before, we really haven't written that Q wave on the backside of the heart, the large R wave in V2. So what can we do? We're suspicious this could be a posterior MI, and this is where potentially putting on the V7, 8, and 9, or the posterior leads can help us better confirm that this is indeed probably some inferior and posterior myocardial infarction. And what you see here in V7, V8, and V9 is about 1/2 to 1 millimeter of ST segment elevation, which is diagnostic in these posterior leads for posterior myocardial infarction. So again, just another tool that if we're not certain, we can put these on and get a lot more information. Of course, we can also put on a POCUS probe, and if the posterior wall's down, that would also be a clue as well. But again, this is just an example of using these posterior leads to confirm a posterior STEMI. I'm going to show this. This EKG is kind of, again, level setting, just so I can show you the next couple. This is sinus rhythm. It's a leftward axis, probably got a left anterior fascicular block, but the key here is the QRS is very wide, and you see this kind of RSR prime in lead V1. So there's an initial teeny little R wave down, and then a wide terminal portion of the QRS, also denoted by these deep, wide S waves in lead 1 and out here in lead V5 and 6. So, this is kind of a classic right bundle branch block. And there's always a discussion whether we can identify STEMI in the setting of right bundle branch block. And I'm going to show you a couple EKGs that I hope convince you that even with a right bundle branch block, which really only affects terminal conduction, not the initial conduction, we absolutely can identify. This is an example here. We see ST segment elevation in the anterior lead. So this is an anterior MI in the setting of a right bundle branch block. And here we see the inferior ST segment elevation with some ST segment depression in the high lateral and precordial V1, 2, 3. So this is inferior MI in right bundle branch block, anterior MI in right bundle branch block. So, all right. This is another EKG that we don't want to miss or misinterpret. And so again, we've got a patient, they're having chest pain, their heart rate's, it's up there, it's in the 90s, not tachycardic, but some evidence that their heart rate is up. Their intervals look pretty good. Maybe the QT interval is a bit long for the rate. It's about right at half to a little over half the R to R interval. So there's probably ischemia going on. And the most striking thing as we're starting to look at the ST segments is we see ST segment depression in 1, 2, 3, AVF, 5, 6, 5, 4, and then these look pretty normal, but we start to see a little bit of ST segment elevation here. And importantly, we see ST segment elevation in AVR. So, so this is a very high risk EKG. It is not a STEMI, but what it does signify is usually multi-vessel disease, significant multi-vessel disease, or left main with multi-vessel disease. So we want to pay attention to this, regardless of whether the patient's pain is resolved or not. This is somebody who needs to come in, should get an early cath. If we can't get them pain-free, they probably do need to go to the cath lab. They likely will need a balloon pump or some other support. Impella CP probably now recommended above balloon pump to control their symptoms. But we don't want to miss this high risk non-STEMI ECG, and again, signified by the diffuse ST segment depression and the ST segment elevation in lead AVR. So this is global ischemia. This is another example of global ischemia. I show this one just to make sure we're paying attention to everything else. This patient's got a lot of voltage here, so there's some LVH going on anytime you're above 10 in AVL and out here in lead 1. We know we've got some LVH. But again, the LVH will not cause this significant downsloping ST segment depression or this ST segment elevation in lead 1 NR. So we don't want to, we do not want to confuse this with ST segment changes that are secondary to a conduction abnormality like LVH. This is, again, global ischemia with background LVH. Okay, everybody probably recognizes this EKG. Again, this is for level setting, and we're going to talk a little bit about more about MI in this setting. So this is again, it's sinus rhythm, but it's big and wide. It affects the initial part of the conduction. So this is a left bundle branch block. Writes these upright kind of rabbit ear complexes in 1 and L if you're kind of pattern recognition, and then loss of forces in the anterior precordium. So left bundle branch block. So can we diagnose acute MI in the setting of left bundle branch block? It is difficult for sure. We have these criteria called Scarbosa criteria. This is an Italian cardiologist who came up with these criteria. The original criteria were concordant ST segment elevation of greater than 1 millimeter in any lead that has a positive QRS, and you get points for that, 5 points. Concordant ST segment depression, again, in the left bundle branch tracing of greater than 1 millimeter in the anterior precordial, anteroseptal precordial leads V1, 2, 3, and that gets 3 points. Or excessively discordant, meaning a large difference between the way the ST segment is going versus the way the major deflection of the QRS is going. That gets 2 points, and it was set at greater than or equal to 5 millimeters. If you had a score greater than or equal to 3, there was 90% specificity for acute MI in the setting of left bundle branch block, but it was not very sensitive. So you can still be having an MI and not pick it up. But if you see these criteria, it's very likely an acute MI in the left bundle branch block. The criterion were modified to take this 5 millimeters down to, say, the ST segment elevation had to be 25% as deep as the preceding S wave. So it increased sensitivity, but maintained pretty similar specificity, but still, it is not sensitive enough to hang your hat on it. You still have to be wary if you're having a patient with typical chest pain and left bundle branch block. And this is independent of whether you know it's new or not. This is just diagnosing MI in the setting of left bundle branch block. And this is what we mean by those criteria. So concordant ST segment elevation, meaning the ST is in the same direction as the QRS. Concordant ST segment depression, again, depression in the same direction. That has to be at least 1 millimeter. The original criteria, the excessive discordance, QRS going one way, ST segments going the other way. And then here, making it a ratio of this amount over the depth of the S wave, but the other criteria remaining the same. So it's just a schematic of what we're trying to look for in these electrocardiograms. So here's an example of AMI in left bundle branch block that meets the Scarbosa criteria. We have excessive discordance. It's well over 5 millimeters, but it would also meet even the newer criteria. We also have concordant ST segment elevation and concordant ST segment depression. So you can diagnose an AMI in left bundle branch block. This is very specific, but it's not a super sensitive sign, and you can miss it. So that those are probably the toughest ones. So I want to look at this EKG because I think this is important. This is a same patient came in with chest pain. We can see sinus rhythm. The PR interval looks a little short, but I'll tell you right up front, this is not Wolff Parkinson White. And the axis looks pretty normal. It's down in L, but it's up in 1, so it's over here on the left. AVR is an inverted lead, but you start looking, and now you're hearing, you're like, well, I've got inferior ST segment elevation and maybe a little depression here in L, but then you look around and you go, oh, but I also have some ST elevation in V3, V4, V5, V6. How can I be like ST segment elevation in every lead distribution? So that's the first clue of what we're dealing with here. The other thing is, you notice these ST segment, they look a lot different than the ones I had been showing you. Most of the ischemic ST segment elevation is kind of coved upwards. These are actually concave. They have this kind of U-shaped look. And then we look a little more carefully and we say, let's look here, and we look at this interval between the P wave and the QRS, or we look here at the interval between the P wave and the QRS, and we say, wow, it seems to be lower than this baseline, and this is what we call PR depression. So this is a pretty classic look, and again, it doesn't always look this way, but if you see this, this should make you think of pericarditis. So diffuse ST segment elevation, PR depression that you can see in many leads here. PR depression is highly specific, but also not very sensitive. If you see it, you're pretty sure you're dealing with pericarditis. So this is a case of acute pericarditis. This EKG I put in here, again, this is a patient who came with chest pain. This was someone I saw, I think as a fellow. And you start looking at this and you're like, wow, those T's look kind of bad. You know, but they're not quite Wellens T waves. You know, you see they're kind of diffuse. The next thing you notice is we've got a lot of volts. I mean, there's a lot of volts in 1, and this is a lot of summed volts in the precordium. They're, you know, the R waves are big enough, they're off the page. We've got an inverted P, deep P inversion for this terminal part here. So this person has left ventricular hypertrophy with secondary ST and T wave changes due to the abnormal conduction related to the LVH itself. Doesn't mean they couldn't be having an infarction, but there's nothing that's clearly ischemic. When you get into this situation, the best thing to do is look for an old electrocardiogram for comparison. So LVH with repul changes. This is another EKG. Again, I'll tell you up front, it's not a STEMI. but it really is an abnormal looking electrocardiogram. It is sinus rhythm. The axis is, again, pretty normal. But these STs and T waves here just don't look quite right, particularly in V1 and V2. So the implications here are not really for getting a patient to the cath lab. They may have come in with chest pain, but there's nothing that looks particularly ischemic on the EKG. But what on earth makes that pattern? So this is Brugada syndrome. And these individuals, if you question them, often have histories of syncope. They have family members who have had syncope or sudden death or ventricular arrhythmias if they didn't die. So we don't want to miss this, but we don't need to activate the cath lab for this. So this is just kind of something you'll see, I think, over a career as you're looking at patients, particularly in the emergency department, but doesn't need to activate the cath lab. And then I'm going to close with this slide, and particularly because Dr. Mitchell asked me about this, and I took this actually from the paper that you had highlighted, but there are several papers that address this concept of occlusion myocardial infarction. And I know it's probably more espoused, I will say, in Europe and among the emergency medicine community than it has taken hold in cardiology. But I think all of these patterns that you see on this slide, we've looked at. Many of them actually are patterns of ischemia that we should be aware of. But just seeing them on the electrocardiogram, although they should make us think of an ischemic patient, unless there's ST segment elevation, there's nothing to point us to necessarily needing to activate the cath lab for those patients. We should certainly do serial electrocardiograms. If we don't see ST segment elevation, for example, we see a Wellens pattern, we see hyperacute T waves, we see the De Winter T, we should be doing serial electrocardiograms. But if we see this Oslinger pattern, or we see the South African flag sign, these are classic ST segment elevations that should make us activate the cath lab regardless, and generally will have an occluded MI. These patterns, although they may have an occluded MI, I would argue, posterior MI, let's do posterior leads. I think there are things that we can be doing to tease out whether we have an infarction, including just recognizing the ST segment elevation pattern. So I don't think it really changes what we do clinically or what our clinical research has directed us to do in terms of primary angioplasty, serial electrocardiograms, high-risk patients getting to the cath lab within 24 hours as opposed to waiting 72 hours or doing stress tests. So that's kind of the cardiologist perspective on it, but I do think it's good for us all to be aware of these patterns and what they potentially mean. So I'll stop there. Happy to take any more questions. I know I went just a little bit over. Thank you all.
Thank you, Dr. Newby, for a wonderful presentation. I was wondering if you have any specific resources for residents learning EKGs. Any favorites?
Yeah, I think probably probably the best book, and it's still around. It's very very easy to read through, to understand. Lots of graphics and things. Is still Dubin's. I think that's probably the best EKG book ever written. There are some, and I will pull these up that we have recommended that are like online programs where you can kind of at your own pace work through electrocardiograms, and I can get those links to you. But if you just want a good book, just to sit down and flip through and look at them, Dubin's is really good.
This is Dr. Miller. I have a question.
Uh-huh.
Yeah. Well, as Dr. Mitchell will testify, whenever they call me about an inferior mind, I'm coming in, I tell them to get right-sided leads. Is that
Yeah.
overkill? I'm
No,
pretty much
I think we underuse right-sided leads, and particularly if there's going to be, when you're calling in the cath lab, particularly at night, there's a window of time, and it really only takes, 5 minutes to put the right-sided leads on and get it, and then you know what you're dealing with in terms of RV involvement or not, what you need to do if they get hypotensive, volume. So I don't think it's overkill at all. I think we underuse them.
because the prognosis is much worse if it's the right-sided infarct.
Absolutely. And part of that is because we don't recognize it, and the infarct gets ahead of us, so to speak. Yeah, absolutely. Completely agree with you.
Okay, well, Dr. Mitchell, I'll put out one last call. Any last questions or comments for Dr. Newby?
Dr. Miller, again, excellent summary. I mean, it just covered everything. That's great.
Terrific.
Thanks. I hope across the spectrum of individuals who are on, I hope it kind of hit a sweet spot, so to speak.
Speaking of sweet spots, Duke is down 1 point at halftime against Florida State. Not that anyone's interested. Dr. Newby and I laughed about this, that you probably know that for any ACC men's basketball game, particularly the original ACC teams, you only need to watch the last 7 minutes because they're all decided in the last 7 minutes.
Yeah.
With 7 minutes being the longest time Dean Smith came back from 13 down to win. But not one to cite that. You still have time for all the second half, and you can see Carolina at 9:30 tonight also. So
I'll probably watch Carolina too. Yeah.
We hope so. Send money, buy more players. There you go. But on the other hand, let me remind everyone, if you did log on through the direct log on tonight, and most people have done this because I've seen it popping, be sure and send us your name and your email so we can give you credit. If you have any questions about the whole program or the process with that, let us know about it. We'll help you solve it. And then I'll remind you, we recorded this program this evening. It'll be available on the SOVA website in within sometime next week. It does not carry CME credit, but if you want to go back and this really, you said, man, this was good stuff, you can listen to it again. And or if you email me, I'll be more than happy to send you a PDF of the slides if that's of help to you. Just let us know. Again, Dr. Newby, this was a terrific presentation tonight, and we are so grateful for your help. Remind you, in 2 weeks, we'll have a program on infectious disease, the stewardship approach, not only to prescribing antibiotics, but to ordering diagnostic tests for infections. So that being said, Dr. Mitchell, thank you so much. This was Dr. Mitchell's idea in the sense of this was a good topic, her and Bruce Mazerit who lead the ER teams. And I so appreciate that because we're delighted to respond to educational needs, gaps as they're known, and help with better care for all of our patients for a healthier community. That being said, best wishes to everyone. Thanks to Vinay and Jennifer for helping this happen, and we look forward to seeing you in 2 weeks. Have a great evening. Bye-bye. Good night.
Thanks.